Good morning. My name's Cecile. I'm going to be the charge nurse today. We just had the Joint Commission for the last few days survey us. Unfortunately, they found our screening process on suicidal patients as a fallout. What occurred was a patient checked in recently in the emergency department after being discharged from the ICU yesterday. When they came in, they were suicidal. The nurse that had that patient did not do their risk assessment screening within the first hour, and the Joint Commission was closely observing that documentation had not been done. That patient got a connection wire from the monitor, tried to commit suicide by hanging themselves with it, but sitters and security were observing, able to intervene and stop that action. The Joint Commission is giving us an opportunity to fix our mistakes. We are rolling out the emphasis of the systematic process for the opportunity to correct our mistakes by identifying of inconsistent treatment of patients meeting suicide screening criteria. We have this in place, but we're not enforcing the importance of it, as we will be reevaluated in 2 weeks by the Joint Commission to see if we've improved and applied our systematic process. I can't not express the importance of this because we had the safety of our patient was at risk. It's in our policy at our hospital to create an environment of care that will foster the accurate identification and successful management of patients who are at an increased risk for suicide or hurting themselves, behaviors that hurt others, themselves. Patients at risk for suicide or self-destructive behavior require intensive support, close observation, and frequent reassessment for their emotional and physical well-being, always, at all times. This policy begins prior to the admission to the hospital and continues throughout the patient's discharge. I'm delivering this message to the nurses, the techs, the doctors, all clinical staff. To the techs, we need our team to help when we don't have the resources. When there are no sitters available, we need techs to change out every hour watching these risky patients. The purpose of changing out the techs is not to be burnt out from being a sitter of a risky patient, but also to have 15-minute checklists completed when you are sitting. I will have forms for sitters stating check marks where the patient is, whether it's the room, the hallway, or another place. Any communication, whether it's verbal or nonverbal, whatever activity that they may be doing, assisting with ADLs, whether they're sleeping, eating, hyperactive, and then if you notify the nurse, observing them, reorientating the patient. This is a checklist. This is going to be turned in to your nurse in that pod, that assigned section. So to the nurses, you'll be turning in these checklists from the sitters to me, and each shift for a nurse will also have a suicide safe environment readiness checklist, and amongst those items are maintaining continual visual contact with the patient, including using the restroom, account for their linens, remove from the room immediately after use, no extra linens in the room, no fitted sheets because they can use elasticity to tie around their necks, ensuring that the patient are in gowns with snaps, no ties on them, and to remove all cords, including call lights, not need for ongoing patient care or removing and securing those items, and that the utensils are accounted for Each meal and arrangements will be made with dietary as appropriate for no sharp objects and plastic spoons. Remove any belongings, shoes, and jewelry on them and give them to their family or have them secured with security. No gloves in their boxes are in the room. They should be in an isolation cart outside of their room. And that any sharp objects used for ADL, these items are prohibited for one-on-one patients. These are the checklist precautions to be implemented and validated at each shift and turned into me at the end of the shift. I want to emphasize one-on-one monitoring and observation. The patient is never to be out of the arm's reach of the assigned staff member. These one-on-one patients are those that have attempted suicide in the last 48 hours. They displayed self-injurious behavior in the last 12 hours. They're verbalizing suicide ideation with a plan to hurt themselves. They have command hallucinations to hurt themselves. They're verbalizing hopelessness, feelings of doom, that they can't live in a life with any change. It's not possible. They have experienced a traumatic loss event or disruption in their social system, their support system, within the last 24 hours. The difference between line of sight observation means at no time is the patient out of visual contact of a staff member. And this can include the usage of a camera if appropriate. Line of sight observation is less stressful in terms of one-on-one monitoring and observation because the patient has attempted suicide past 48 hours. There hasn't been any display of self-harm in the last 12 hours. And they're verbalizing suicide ideation but denying having a plan to hurt themselves. They have no command hallucinations to hurt themselves. They're verbalizing hopelessness within the last 24 hours, but they are in elopement risk. They're extremely confused within the last 24 hours. So prior to the discharge, the nurse must complete a final reassessment to have the resources to keep our keep our risky patients safe. Otherwise, notify the doctor. To the doctors, we must get an order for a sitter for these suicidal patients in order to keep them safe. Prior discharge planning, the doctor has to perform a final assessment of the patient's suicide risk that should include current level or presence of suicidality, presence or absence of a plan, review of any significant hurt to themselves or activity while they were in the hospital, and justification to continue, heightened level of observation or suicide precautions, clinical justification for discharge or transfer to a lower level of care. This assessment is to be documented in the patient's medical record. Do I have any questions? I know it's a lot of information. I will provide these checklists when I make my rounds. The Joint Commission will be coming in 2 weeks to see if we're in compliance and making improvements to enforcing these policies. Feedback will be shared amongst you guys in the next 2 days. You guys are an awesome team. We can do this. Let's have a great shift. Thanks, you guys.